All right, a very big welcome to everyone joining us tonight for update number 6 for the COVID-19 primary care updates, and a very big thank you to PHN, Adelaide PHN, for hosting us this evening. I'd just like to first of all acknowledge the land that we're meeting on this evening. For me here, the land of the Ghana people, and pay my respects to elders past, present and emerging, and really thank the custodians of this land for caring for this beautiful country that we are so grateful to live on here in this wonderful world. I'm going to step through and introduce our panelists that we have for this evening's webinar. And this one was really focused on a practical prescribing webinar, focused on what are the key challenges that we're going to see now with PBS prescribing Apaxlovid and Molnupiravir. And we're so delighted that we've got a really expert group of panelists with us this evening. So I'm just going to step through who we have here, and then we'll move to a COVID-19 update. So first of all, we have Dr. Melanie Smith, who's our medical lead of the GP Liaison team here at SA Health. And Mel's going to go through where we're up to currently around the prescribing, the criteria, what does it mean, the state pile, the PBS stockpile, what does this all mean together? So she's going to go through that. Then we're going to run through a series of case studies, and we're so delighted that we have the very, very talented Deb from DATIS, and also Joy from DATIS as well here with us this evening. So of course, as we all know, the absolute experts in this space. Anything you need to know about any prescribing, any complication, or we're not quite sure what the interactions are, it's generally DATIS who come and solve our problems for us as GPs. So we're absolutely delighted that we have Deb and Joy with us this evening. In addition, we have Dr. Jackie Yeoh, and you're all familiar with Jackie as medical lead of the CALHN COVID Care Centre. And Jackie's been pulling a number of late nights to keep our patients safe in the community, administering all sorts of things, but particularly has been doing a phenomenal job now that we've switched over to remdesivir and giving remdesivir for community patients. And then we have Dr. Jenni Goold, who, as many of you know, Jenni's been with us now for, I'm going to say, Jenni, you've been part of this now for 793 days, given you were there right at the beginning when we went into the emergency management with me. And Dr. Jenni Goold is clinical lead of the COVID-19 GP assessment team and does a phenomenal job overseeing that fabulous group of GPs who keep our patients safe in the community through our high-risk hub. So thank you to our panellists for joining us this evening, and of course a very big thank you to Adelaide PHN for hosting tonight's update number 6 for the year. So I'm just going to give a COVID update, because there are quite a number of key things that have been happening in the COVID world in the last few days, and particularly the most notable has been the transition to the Public Health Act. And this really didn't come as a shock or surprise to many of us who've been in the system, because of the fact that the legislation did pass last week to enable the COVID amendments to go under the Public Health Act. So essentially that means we've been in this emergency declaration under the EMA 793 days. We had been in that for that period of time. The legislation, the directions that sat within that were then transferred under the Public Health Act. So there's no real change in terms of COVID isolation provisions, where we see requirements for vaccination for healthcare workers, requirements for mask wearing within general practice, that still remains there. And then the other area that's still sitting under as well is the residential aged care direction. Now that has been updated as of Monday to now require influenza vaccinations to be administered, and we've got a couple of weeks leeway on that, but it is now a requirement for the 2022 dose to be administered. It was previously the 21 dose in that direction. So the new changes that have come in with the Public Health Act to be aware of. In terms of though what it means for SA Health, we are no longer now the control agency as part of COVID-19, which means decisions or changes that happen around directions or responses that we have for COVID move in a different way within our department. So we're just working through what that governance structure looks like, but essentially it should be no different for the community, except reassurance that if we were to put on additional restrictions or changes, that would need to go through a different process and would essentially need to be looking at whether we would need another declaration under the Emergency Management Act. Now, so that's a little bit about where we are with the transition that came into effect yesterday. Now, the next point I wanted to talk through around was increasing influenza cases. Just briefly, I know this is a COVID update, but I can't help myself to digress into influenza, because this is going to be very important for us over the winter months. We've seen increasing cases, particularly in the eastern states, and we've heard a lot about the cases in Queensland. around where they are seeing their influenza cases. Here in South Australia, we're not doing too badly in terms of our overall cases here in the state. I was just looking here at my numbers I had here. We're at 1,195 influenza cases so far this year. We've had 126 hospitalisations as a result of influenza, and thankfully 0 deaths so far here in the state. But interestingly, we are not really testing high volumes of influenza here. So whilst we're seeing big numbers interstate, and particularly much higher than we would expect on a usual year, and looking at the 2018-2019 patterns, we are not really testing large numbers here in SA. In fact, currently the only way to get influenza testing is through that GP referral or to a drive-through testing site, or if you're an inpatient in the hospital system and you're unwell with respiratory symptoms, you will also be tested with a respiratory panel. So we're just working through what that's going to look like, the future of testing here. How does that integrate now with COVID testing as well at some of our sites? And we'll have more information that in the coming weeks to see where we shift from COVID testing to influenza testing. And that will be very much determined by hospital capacity that we're seeing, but also around where we see the uptake of the flu vaccine, which leads into my flu vaccine point. So we're currently sitting at 64% of individuals aged 65 and over have had a flu vaccine, which is actually phenomenal rapid uptake, which is fabulous to see. But we would like to see more individuals be vaccinated. We're still sitting at 10% of children under 5, and of course it's 6 months to 5 years being on the national immunisation program. Individuals who have comorbidities, chronic disease that meet the criteria, and then individuals aged over 65. And this year again, it's flu vaccines can be administered from the pharmacies and also in general practice as well. We are not looking at running a mass flu vaccine approach or clinics here at SA Health. So we've had some questions asking, are we looking at rolling out mass vaccines, flu vaccines? We are absolutely not. There's no intention to step into that space. That really is key core pharmacy, general practice business now around delivering flu vaccinations. But we are, of course, looking at, is there a need to look at a wider policy or wider uptake and encouragement of flu vaccines, like we've seen in Queensland and New South Wales with free flu vaccines for all age groups. And that's a policy position that's being actively reviewed here in the state to see where the evidence stacks up around that and what impact that may or may not have on our hospitalisation bed capacity. So that's a bit about the flu vaccine. Of course, encouraging as much as possible children who are under 5 as part of that program, and then of course over 65 years as well to be vaccinated. And of course, if your patients do have symptoms and they've had a negative test for COVID, then please encourage them to have a respiratory panel. It does require a form to be taken to one of the drive-through testing sites. We've also got the GP respiratory clinics as well that are continuing to operate that are able to order respiratory panel testing for patients as well. The next point I just want to mention, I feel like I'm on rapid speed, but we've got to get to these fabulous case studies on prescribing. But very quickly, just around changes to community care. And we get lots of questions around this. What is this? What's the next steps now where we're heading in the management of COVID in the community? So we've been very lucky that we have the partnership with Health Direct currently. And so Health Direct have the National Coronavirus Helpline. All patients are directed to that service. But I don't think what patients quite realise, or what our community members realise, is that team is a nursing team that actually assess patients and can redirect their care either into our high-risk team, which is our COVID response care team, redirect care back to their usual GP, so back to yourselves if they can get an appointment, or back to one of the GP respiratory clinics, and in some cases they refer directly to 000. So that team do a really phenomenal job. They're averaging about 400 calls a day, and then we get around about 35 to 40 escalations a day to our high-risk team currently at the moment, with a relatively stable case number that we've had here in the States, slightly dropped off, but relatively stable numbers. However, post June 30th, we will be integrating further into the virtual care space. And the reason that we're doing this is we want to make sure that we're here to support GPs in the community and not take away and not segregate care out in a space where we know this really does sit within usual general practice. And it's much better for our longer term planning as well if we don't have a separate COVID pathway, but we integrate into a respiratory winter planning model where we're supporting and providing escalation advice for patients in the community through their usual GP. So we will be continuing with Health Direct through that assessment process, and we will be continuing with a COVID community hub which will be aligned with our virtual care service, and that hub will be really focused on supporting vulnerable groups. So we are very pleased though that we will have GPs as central to that hub moving forward, and we're looking forward to providing more details about how GPs can get more involved in that program and to employ GPs within our virtual service, which we think will provide longer term benefits to the state by having GPs integral to how we are coordinating care out of hospital. So that's really around the community hub, and we'll, as I said, provide more details coming out. And the final point I just want to mention was around the 4th winter dose of COVID, which was expanded, announced today, that we will see that expanded criteria now really focusing on individuals with chronic diseases can now access a 4th dose as approved by ATAGI. So really pleasing that we have seen that change. So we expect there'll be an influx of requests for people to either walk in. So there's no bookings now at the SA Health site, it's walk-ins. And we will see, in fact, the booking system stop at the end of the month, but walk-ins to the COVID hubs for vaccinations, and then of course expecting an uptake in pharmacies and general practice for the 4th winter dose. Oh gosh, there we go. 5 points that we wanted to update tonight, and then apologies, we will get to the main focus of tonight's webinar being on prescribing. Just very quickly, if that's okay, I just wanted to present, I love talking about the modelling, as you know, in these webinars. I just think it's really useful to see that fluctuation of cases. We're having that second peak there at the moment, particularly focusing just on this slide here. You can see it has our ICU occupancy as well. So a little bit above the line of where our prediction line is, but that's been remaining relatively stable. Same with our active case numbers, just a little bit above the predicted line, but now stabilising and plateauing there. And again, hospital occupancy had a little bit of a spike in the last couple of weeks, and now we're stabilising off again, it looks like, which is good. So I think we're just going to continue to see these up and down projections, and that's absolutely expected and consistent with the other states. Just the trends around Australia, and apologies, it's a quite small slide, so you might need to look at these later or zoom in on these, but particularly just wanted to emphasise, because we've had quite a bit of talking as to why New South Wales and Victoria are a little bit different in their case presentations. But I just want to say a very big thank you to Jo Varney. This is her fabulous work at the Royal Adelaide Hospital in mapping this data for us. And particularly, you'll note that the top set of graphs is Victoria and New South Wales. Interestingly, New South Wales had that peak and then they've dropped off, and Victoria is having that increase now of their cases, and particularly their hospitalisation, which is that second graph along. You can see we're tracking very similar to Queensland at the moment. So again, we had that second peak come up and then tracking down, and Queensland's still maintaining higher numbers than us. And then you can see their hospitalisation rates. Again, it's following a very similar curve, but New South Wales numbers have dropped off, which is good. Victoria is just slowly climbing. What we are going to see though now, it's going to be harder to map across the states. And the reason for this is we're all reporting in different ways. And particularly as we have more incidental COVID, so people coming in for other reasons into the hospital system, but they have COVID. So we routinely screen everyone coming into our health system. Other states are not routinely screening people coming into their health system. So we do get a slight, we look at the numbers and think, oh, why have we got more admissions here in SA for percentage wise? But in fact, it does align based on where we're reporting, but we do report in and test everyone coming into our health system. So we pick up a lot of incidental COVID, so people not admitted their COVID, but they happen to have it on testing. And final thing I'll just mention is genomics, and then I'll stop talking. And I wanted to mention that we are still continuing to see BA2. Would have heard through the media that we've also had a couple of cases now of BA4 and BA5, and just very grateful to SA Pathology for this data that they've mapped out through their team. You can see where we had the Delta, then we went to BA1, BA2. We're still getting a couple of tail cases there of BA1, and then you can see the BA4, 5, which you can see there mapped on there. So not really seeing very high volumes, but remember, this is only a sample of the cases, and particularly it's sampled from a hospital perspective and individuals who identify as being international travellers. So good news is though that we do undertake genomics on the admitted patients, particularly the ICU patients, and we're not seeing that is signifying that it is a BA4-5 around severity. So that's good news. And that's all from me. So I'm going to leave it there. I'm very happy for people to post into the chat. Into the Q&A. Please don't post in the chat, we might miss things. Please post in the Q&A, and as I said, we'll move through questions, and Mel Smith and myself will be monitoring that. And I'll hand over to Mel now. Thank you.
I just have to mention as well that this is an interactive webinar, so people can raise their hands, and I think at the end of each presentation, if we ask questions, I could actively add them to speak any questions they want to, or any scenarios that they want to speak. Is that okay?
Fabulous. I love an interactive webinar. Wonderful. All right.
So there is a question already for you, Emily. Unfortunately, let me just find a few that was. It was Ethan. Ethan, are you still there? Did you want to speak to Emily? Bear with me. Sorry, it's disappeared. So I don't know where that's gone, Emily. Apologies.
No worries. Very happy to answer questions in the Q&A box if they specifically come related to COVID, but we're looking forward to this being a really interactive webinar around prescribing. Thank you.
Perfect. Thank you.
Thanks, everyone. So on to the kind of the main meat of this presentation today, and we've got 3 case discussions to come from Jenni, Jackie and Deb and Joy. So we're really hoping tonight to sort of help everyone get a feel for the realities of prescribing the COVID oral antiviral medications in practice as a GP in the community, with the kind of issues you're going to come up against with your patients. And particularly that will mean that we end up focusing a lot on Paxlovid, which is a little bit more complicated to prescribe. But yeah, please put forward your questions in the Q&A, and I know that people will hopefully have come along with some questions around their own patients and particular scenarios that can be a little bit thorny. I'm just going to start off by doing a quick run through the main pathways to access these medications for your patients, and look at some of the PBS criteria in general and some of the sort of broad tips and tricks on prescribing. And then we're really going to delve into that with the case discussions following on. I did just want to give a big shout out to Kara Kolopelnik, our wonderful pharmacist who presented a few weeks ago on these medications and gave us some great information on prescribing. And this presentation is really trying to build on that one that she did then. She's given some great input to the material I'm presenting today. I'd also like to thank Dr. Belinda Capon, GP extraordinaire, who's also been really helpful through her work with Gpat and some of the resources she's put together to help in her work prescribing these medications. And as always, to Joy Gailer and Deb Rowett and the whole DATIS team, who have just been the absolute foundation of the process around so much of this prescribing. So I'm just going to move through these. There we go. Oh, back up. Before I sort of go any further, I do want to reiterate to everyone that this space is really ever changing. And as you've probably noticed, guidelines and knowledge about this disease and the medications involved changes on a almost daily basis, it feels like sometimes. So the information I'm presenting here is correct today, but I can't guarantee it'll be correct tomorrow. So any resources and advice that you receive here, it really needs to be considered in the context of the ongoing updates and changes that may occur and when they're applied to your individual patient. So what are the main medications we're talking about here today? So the antivirals that we're currently using for people with COVID in outpatient scenarios, so these are patients with mild illness, Paxlovid, which is sort of our first line choice, which is a combination of 2 different antivirals that I cannot pronounce properly. There's also remdesivir, which is actually an intravenous preparation that our COVID care centres and the LHNs often will administer, and that's accessed through the National Medical Stockpile. And then there's Lagevrio or molnupiravir, which was the first oral antiviral drug to come onto the PBS and has commonly prescribed and available and has been pre-placed in a lot of residential aged care facilities and some other high-risk settings around the place. There are some other medications that have been used previously for these kind of patients and things to think about. The monoclonal antibodies, sotrovimab and Ronapreve that we were using a few months ago quite commonly for patients with mild illness, they are not currently in use because their lack of effectiveness against Omicron. There's also, you may have heard a little bit about Evusheld, which is another monoclonal antibody medication that's actually been used for pre-exposure prophylaxis in people who are profoundly immunocompromised and are at high risk of really poor outcomes. So that's got a very limited application in our state, and it's not something that we as GPs in the community will generally be prescribing. And the other thing that we sort of think about whenever we're treating COVID patients in the community is, apart from general sort of symptomatic management, is considering venous thromboembolism prophylaxis for pregnant patients who may have increased risk factors. So they're kind of the main things we're thinking about as GPs. I also just want to point out that what we're talking about here is prescribing these medications for adult patients. While there has been some changes to the approvals for these medications, and there certainly is some scope for the antivirals and the monoclonal antibodies to be used in children over 12 years and over 40 kilos, I think. Really, that's only done with involvement of paediatric specialist services. So if you have a paediatric patient that you're thinking, oh, this is someone with a whole lot of medical complexity who may benefit from these medications, it's probably someone you're going to want to be referring to the COVID Kids Service through the Women's and Children's Hospital, and you really want some specialist paediatric involvement there and making decisions around whether they should have these medications. So there's two main ways that people can access the oral antiviral medications, and remdesivir is an IV, and that's through the National Medical Stockpile, which is sort of the Commonwealth supplied medication that's come across the country and is really supplied through the local health networks. And that is where we initially started enabling access for patients to these medications through the centralised online referral process, which has worked really effectively and has involved administering intravenous medications through the COVID care centres. What we really wanted to talk about tonight, though, is more about the PBS authority prescription for Paxlovid and Lagevrio. And so they're the two medications that we can get under specific criteria and access for our patients. So that's what we want to focus on tonight. It is important to note that the PBS criteria for the prescription of these medications is slightly different to the eligibility criteria to access a national medical stockpile criteria. They kind of overlap a lot, but they're not exactly the same. So there will be a subset of patients who probably are at higher risk of poor outcomes from COVID, but they may not meet PBS criteria. But they may be eligible to access NMS medication. So we kind of always have to keep in the back of our mind, if a patient we're looking at doesn't meet PBS criteria, might they meet the NMS criteria, which do tend to change and be updated quite regularly. And that's why we have to kind of keep an eye on what's going on with the state guidelines and the centralised referral process. So when you're thinking about what to prescribe for your patient, the first thing to think about is that eligibility. And as I said, do they fit the criteria for Paxlovid or Lagevrio? If not, then we need to think about NMS access guidelines. The next thing to think about after you've worked out whether they're eligible in the first place is which one's most suitable to apply to your patient in their clinical situation. Paxlovid is generally our first line treatment. It's got the greatest efficacy and easiest access, but it does have some complexities around drug interactions and suitability for people with different comorbidities. So there may be a significant number of patients who might be eligible to access the medication, but it might not be the right drug for them, or it may require significant changes to their existing medication regime. So people for whom it's decided that Paxlovid is not clinically suitable may be able to access the IV remdesivir through the National Medical Stockpile, and that's when we'd kind of go with the centralised referral process and make this work through our LHNs in our COVID care centres. Alternatively, there may be people who cannot have Paxlovid, they might not want to have intravenous remdesivir, or they may not be suitable for that either, and then we can think about Lagevrio, and that's has far fewer drug interactions. There are some concerns around contraception, but it's probably a lot easier to prescribe. And certainly if you do decide that your patient is eligible for this medication and is suitable, go forth and prescribe. So having a quick Cook's tour of the PBS criteria, there's a number of things that your patient needs to meet to be able to access this. And probably the first thing is to really think about they must have a positive PCR or a RAT test. And I just wanted to point out that some people have interpreted having a verified RAT test, as is mentioned in the PBS criteria. Some people have assumed that that means that they actually have to have had a supervised or somehow validated RAT test, positive RAT test result. It's important to understand that in kind of the details of the PBS criteria, really all that needs to happen is that the prescriber needs to be satisfied that your patient has had a valid positive RAT test and record that somehow in your patient records with as much information as you can. It does not necessarily mean you actually have to see them do the RAT test or see the positive result yourself. That has been a barrier on a couple of occasions where people have felt they needed to have a medically supervised RAT test, and it's not the case. Obviously, the next thing the patients need to do is have at least one sign or symptom of COVID-19, according to the PBS criteria. And they're pretty broad. And I'm pretty sure that anyone with COVID-19 could be considered to have at least one of these signs or symptoms. If not some headache, some muscle aches, some nasal congestion, pretty sure everyone has got some fatigue going on somewhere. The next thing to think about is their age criteria and their comorbidities. So for patients who are 65 years or older, or 50 years or older if they're Aboriginal or Torres Strait Islander background, and considered to be at high risk of deterioration to severe disease, or people who are over 18 years old and moderately to severely immunocompromised, your patient needs to fit one of those criteria. So in terms of the criteria around what constitutes high risk, there's a list of risk factors, and for your patients 65 years and over, they need to meet at least 2 of those criteria. Now, it's important to note here that one of the criteria is that they have had less than 2 doses of COVID vaccine, so they're not fully vaccinated, or if they're over 75 years, is in itself a risk factor. So essentially what that means is if they're over 75, they only need one other risk factor. If they're over 65, they need to have 2 of the factors listed here. In terms of defining moderately to severely immunocompromised, the definitions of immunocompromised are slightly different in the PBS criteria as compared to some other places like the National Clinical Evidence Task Force and the state guidelines. So make sure you check the specific PBS criteria around immunocompromise. Obviously, there's sort of the basic primary or acquired immunodeficiencies. There's also specific use of particular immunocompromising medications or therapies in the last 3 months, and some very specific conditions that are considered putting them at higher risk or being in an immunocompromised state. The other specified conditions section, actually the wording kind of, lists a number of conditions, but it's not really specifically limited to those conditions. So there's a little bit of wiggle room there. But really, I'd recommend you check the detailed criteria in the PBS when you're going through this. And the last important point is that the medication needs to be initiated within 5 days of symptom onset. So we talk about the first day of symptoms of COVID as being day 0, so they need to start by the end of day 5. So this can be a different date to the date that the patient has actually had their COVID test, so it might be different to their days in terms of their isolation or illness requirements from a kind of that legal point of view. It's really about symptom onset. So yes, if your patient is PBS eligible, go for it. Consider whether they're suitable to actually have Paxlovid. And that's where you really get into the nitty-gritty of determining whether they have any contraindications or specific medication interactions. And our pharmacists and GPs who've got lots of experience prescribing these medications will be delving into this a little bit more in the case discussions. But the bottom line is, if they're suitable, do it, prescribe it. If not, you need to consider whether they're eligible for the National Medical Stockpile access, and probably the best way to work that out is to go to our SA Health COVID-19 mild illness treatment and referrals webpage. There's a little screenshot of that page that I've probably shown many times before in previous webinars, and that's where you can find all the eligibility information and the online referral form to see if they meet the criteria for things like remdesivir. There may be specific scenarios where it is appropriate to use the NMS medications. So patients who don't fit the PBS criteria but are still at high risk of deterioration, and that can include people who are under 65 and unvaccinated, people who are but sort of between 50 and 65 and unvaccinated or partially vaccinated, but they have multiple risk factors, or some of the younger Aboriginal and Torres Strait Islander patients who are unvaccinated and also have multiple risk factors. Or even if your patient just can't access PBS stock via community pharmacy. We're seeing more and more retail pharmacies stocking this medication and getting access to it, but there may be times when that's just not possible. I mean, particularly in some regional areas, it may take a little longer for pharmacies to get that in. So there may be times when you need to think about NMS. And of course, then there are patients who don't have access to PBS or Medicare or not privately insured. And these medications are expensive to access privately. They cost over $1,000 each for a course. So there may be a case for using LHN to access these medications. And just a quick screenshot of our mild illness treatment page, and just sort of trying to highlight where you can find the guidelines document that has the flowcharts outlining who's eligible under NMS and what medications are appropriate. And it has some great resources on that website about medication interactions, contraindications, and what is most appropriate. So remember, important points, tips and tricks for these medications. They should not be used for pre-exposure prophylaxis or post-exposure prophylaxis. So we have seen some people trying to prescribe these medications in those scenarios, but it's not appropriate and they're not indicated for that under the PBS. Also, please don't just prescribe molnupiravir or Lagevrio because it's easiest and simplest. It's also significantly less effective than Paxlovid or remdesivir. So if you can, let's try and access the more effective medications for our patients. We've also seen some people considering giving patients a script for Lagevrio just in case they might get COVID, or just in case they can't access Paxlovid or remdesivir. This can be quite problematic and interfere with their longer-term optimal treatment. And we've also seen a few cases where people have been a bit uncertain about trying to access Paxlovid or remdesivir through the National Medical Stockpile, and they've actually started people on Lagevrio while they're waiting. And this becomes really problematic because we aren't supposed to be prescribing more than one oral antiviral in these situations, and it will actually disqualify them from being able to access those other medications. So this all, I'm sure, after a quick whirlwind tour of the PBS and prescribing, probably makes you feel like your head is exploding. So there's two main central kind of sources of help in this situation. We have DATIS, who are just a fabulous resource that we're very lucky to have access to in South Australia, the Drug and Therapeutic Information Service. And you can call them Monday to Friday, 9 till 5, I think. On the number listed there. And we also have our new clinician advice line that is open for access to our Gpat duty doctors who work within the COVID response care team. And that's open from 9 till 5, 7 days a week for access to our duty doctors. And outside of those hours, that number will also get you through to our CRCT nursing staff who can help with any queries you might have and help access resources for your patients. So, thank you. I'm happy to take any questions at any time through our health.covid.doctorinfo email address. And again, thank you to Cara, Belinda and Joy particularly. And I would like to pass along to Jenni, I think, who is doing the next case presentation, unless there are any questions.
Okay, well, hello everyone, and thanks, Mel. I'm just, you've stopped sharing so I can share. Great to have so many of you on board tonight, and I just wanted to reiterate, as Mel said, a huge thank you to everyone who's working so hard in this space, and I'll just use it also to thank my fabulous Gpat team who for the last 793 days have helped me stay sane in this space and do the fabulous work that we do. So we've got a case to kick things off. And I know Mel said, you know, thinking about prescribing in this disease modifying space has some complexities, but I think that's what GPs do really well. We turn complexity into practicality. So I'm sure you will be all over this. So we have our fabulous Peggy. She's 66. She's got the fairly standard symptoms of mild COVID. She had a positive test with symptoms that starting the day before, and she's had a single vaccine. So, oops, I can't. Oops. Okay, so additional information about Peggy. She's got asthma, moderate to severe, currently well controlled. She's got high cholesterol. She checked her bloods just before Christmas last year so that she could enjoy the Christmas celebrations without guilt. And she's on some medication. So Seretide, Ventolin, and she takes Simvastatin. No other medications and no other recreational drugs or over-the-counter drugs. And I think it's really important to explore this with your patients. I'm not quite sure who's responsible, but zinc seems to almost be something that just about everybody's taking. And so it's really important to ask patients about things that they do buy from the health food shop or are non-prescribed. And recreational drugs is also interesting because some people won't necessarily see the medications that they take as recreational. They might use their drugs such as marijuana for managing symptoms. So we need to get a full medication history so we can be sure that we can prescribe with confidence and safety. So having trouble with my button here, but anyway, we're on to examination. So the joy of examining, I think everyone's got really comfortable in this space with examining over the phone in the world of COVID, and I certainly know that in the Gpat team, that's what we've done. But of course, there are options if you've got a patient that needs face-to-face assessment. But generally speaking, we're having a chat with Peggy. She sounds really well. She's able to complete her sentences. She doesn't have access to oximetry. There is still some kits available in the community for high-risk patients. She's got a mild fever. And what's really important here is to calculate the BMI. Now, I know sometimes with busy GPs, we just make an eyeball and you think, oh, that's probably okay. And I've specifically with Peggy, her BMI is just over 30, which is the cutoff. And so it's really important to make that calculation rather than just simply think that it's okay. So looking for what can we treat the marvelous Peggy with? Mel's been through the options very well. Paxlovid is, as we know, a combination medication with nirmatrelvir and ritonavir. This is really our first line treatment. This is, you know, the one we look to see if patients do fulfill criteria for, and that they don't have any contraindications, and so that we can prescribe it. We of course have the other medications such as molnupiravir and remdesivir if Paxlovid does not fit with our particular patient. I won't go back through the PBS criteria because Mel's done that extremely well, but it's well laid out when you're working through to see if your patient's eligible. This is a summary that we use And it's just useful, I find, for having a quick look at if patients are over 75, they need to have one of the risk factors listed here and that Mel went through. If they're over 65, they need two. And those Aboriginal and Torres Strait Islander patients over 50 need to have two. So let's go back and have a look at our case. Is Peggy perfect for Paxlovid? So let's look at her eligibility. She's got a verified COVID positive result with a PCR done on the 24th, but her symptoms, when we take that history, actually started from the day before on Monday. So her day 0 for the purpose of deciding if she's eligible for treatment is actually the 23rd. She meets the criteria with having at least one symptom, as Mel explained. She's over 65, just at 66, and having a look at those the list of high risk factors. She's had less than 2 doses with only 1 vaccine. She's got moderate to severe asthma requiring inhaled steroids, and she just makes it over the line for BMI, but she fits in because she has the other 2 risk factors. So yes, Peggy fits the criteria, but is it perfect for her? So we need to make sure she's got enough information to make an informed decision about whether she wants to go down this path. And there are some fabulous resources for you to share with patients, and I've got them a bit further in the presentation, but they are all there on the linked on the documents Mel's referred to earlier. We also need to be sure that Peggy can work out that Peggy can collect her medication, because of course, if she's COVID positive, she can't hop on the bus or jump in a Uber and pop to her nearest pharmacy. So she will need to have a mechanism for getting that medication. And also the medication is of a reasonable size, and some people do have trouble swallowing large tablets. So we need to think about that as well. So we know that with looking at medications, that it's really important to get a full medication history. If we're looking to hold or change drugs for the use with the disease modifying treatments, or in particular Paxlovid, then it's useful to have that history. If someone's had an acute cardiac event and has only been on their medication quite recently, then you'd be much more reluctant to jump in and change medication for someone who's got a very stable history. We've talked about over-the-counter and recreational drugs. Contraception, I think probably we should never assume for anyone, but at 66, I'm probably going to put my money on the fact that Peggy does not need to think about contraception. And then we really need to look at the potential interactions. And so it's a really good idea to use a couple of resources to do this. And I know DATIS and Deb sent through earlier today, there are a variety of tools. The Liverpool Drug Interaction tool you can download on your PC, or you can even have the app on your phone, as well as UpToDate and other resources. So I haven't come across anybody who's had an allergy to the 2 combination drugs in Paxlovid as yet, but it's certainly important to check. So we know that our Peggy's on Seretide and Simvastatin, and this link would take you through to the Liverpool drug interaction checker, but it's pretty slow to load. So I've just done some screenshots. It will open to this page and you'll select down the drug of choice, which is Paxlovid here, and then you put in the drug that you're wishing to explore interactions with. We've got salmeterol, and then it comes over here, do not co-administer. And this arrow over here has a drop-down box which would give us all the information that we need to know about that drug interaction. And this is that screen here. So it goes through the details. A4 and ritonavir inhibits this. So we may see an increase in plasma concentration of salmeterol and hence the cardiovascular, well then predominantly cardiovascular or the beta agonist effects with QT prolongation, etc. So it's not recommended to use in conjunction with Paxlovid. So how do we make Peggy Paxlovid perfect? Well, we need to look at changing her medication from serotype to avoid this interaction. So ideally, we would be looking to switch to the same or a similar inhaler device. So if she's on an autohaler, then looking for something similar. If she's already using a puffer with her Ventolin, then and her technique's reasonable and she's got a spacer, then we can probably move into that space. But there are quite a number of options available. So we need to think about matching device and usage and dosage. Simvastatin. So I think there's a little bit of a misconception that if anyone's on a statin, that kind of rules them out or we need to hold their statin. That is not the case. Most of the other statins like fluvastatin, pravastatin, etc., they can be used in conjunction with Paxlovid. It's really Simvastatin and to a lesser extent atorvastatin, because these are metabolized also by the isoenzyme. So hence increasing plasma concentration and then the adverse side effects with the myopathy and potentially rhabdomyolysis. So in this instance, we probably would not recommend that Peggy be on her Simvastatin. And given she's been, stable, she doesn't use it she hasn't got any ischemic heart disease. She's been on it for years, and she had a cholesterol check that wasn't terrible in December. Then I think it's quite reasonable and quite safe. We could hold that medication for the recommended 8 days. Now, you could look to change that medication to something that's safe to use here, and that may be appropriate in certain clinical scenarios. But I recommend that you want to think about, there are other things about getting medications, about cost involved in changing someone for a short term. So some medications you will need to change over, others you may simply be able to hold for that 8-day period. And if you're unsure, then in more complicated cases, then obviously reach out to the specialist who is involved in that specialised area of care and get some advice about the medication. So what's next for Peggy? There's some other important issues to consider. Liver disease, we know her liver functions were okay. Bariatric surgery might affect absorption. We certainly need to think about blood pressure in people with high or borderline high blood pressure, because the Paxlovid can increase the blood pressure. And of course, we need to think about interactions with things like anticoagulants. We've been through that medication history so that we know she's appropriate. Other considerations. So we know that she meets criteria. We need to think about the dose. And so renal function is important in this space. So if someone's got normal renal function with the GFR of over 60, prescribe Paxlovid standard dose for 5 days. If we've got an impaired renal function, we reduce that dose with the Nimratrovir down to half strength. And if we've got a GFR less than 30, well then Paxlovid is not the way to go and we need to look at alternatives. Well, Paxlovid Perfect Peggy is ready because we know that her GFR was above 90 in December. Now, there's nothing in her history to make us concerned that she's had any renal insult since that time, and we're within 6 months, so I think you can feel comfortable. If you were unsure or there was someone who'd had a longer period of time or more complex story, then it may be that you need to organise for them to have a blood taken prior to starting the medication, and that can be arranged also. So there's lots of information out there, and I've put this COVID treatment fact sheet in, which is really good, and we in our team email this out to patients for them to read. This is just part of it. It couldn't all fit on, but it certainly explains the tablets, the side effects, etc. It's available in other languages, And it's also Pfizer have released a resource for our Indigenous patients. And there's quite a number of resources available for information in this space. But you can get this off the website, and Mel's links would have included that as well.
Jenny, can I jump in? There's a question that I think before we keep going, there was a question around, could you clarify what you're supposed to do with the patient's serotype?
So change her off the serotype and move her on to something like Symbicort is probably reasonable, or Flixotide. So you could put her on Symbicort. She's using a puffer already with the Ventolin, so you assume there's a spacer, but that would be a reasonable way forward. All right. Okay, so what happens if our patients miss a dose? So for it to be effective, they need to take those full 5 days. If you miss a dose and it's within 8 hours, tell the patient to take it as per normally. If it's more than 8 hours, then don't take that next dose. Just take your next scheduled dose. Don't try and double up the dose to catch up. And if the patient's missed a number of doses, then we need to reach out and let you know, so that you can have a look, because the efficacy of the drug would be much reduced with missed doses. Side effects, I mean, the side effects are fairly minimal and often very similar to COVID, so not always easy to distinguish, apart from the metallic taste. Generally, so with patients, it's not always easy to know if it's the medication or the COVID itself, but obviously if symptoms are such that they're, severe or interfering with that patient's, to a certain extent, then obviously you need to address that. We've talked about blood pressure. Of course, there are the more serious side effects and potential with allergy. I've not seen any of this. DATIS have done a lot more of these, and Jackie in at CCC, so they may have. And we also need to ensure that our patient's not pregnant or wanting to become pregnant or breastfeeding. And I think we're pretty confident Peggy's left those days behind her. So we've decided that Peggy's perfect for Paxlovid. We've changed her serotype to Symbicort. We've got her to hold her Simvastatin for those 8 days, the 5 days of treatment plus 3 further days. And we've given her an e-script, and she's organising that for her family to pick up for her. So I think it's really important to think about follow-up of these patients, checking in with them the next day once they've got the medication. Does it make sense? Are they sure what to do with it? Are they able to swallow the tablets? And depending on the age of the patient and their health literacy, you may want to follow them up again in a few more days just to see how they're going. That's our case of the Paxlovid Perfect Peggy. And it's a fairly simple but fairly straightforward case that is something that comes across our desk a lot in this area. So happy to take questions, and I know Jackie's got a case to follow, and I just wanted to thank everyone again for all the work you're doing in this space.
I have one question for you, Jenny, that's been asked that I'm sure you'll be completely across. How long, this is switching to VTE prophylaxis for pregnant women with risk factors, how long do they stay on the VTE prophylaxis?
Yeah, 14 days. So 14 days from start, and if they've been hospitalised, 14 days from discharge. They may have started it earlier in hospital.
Thanks, Jenny. And there's been some comments in the Q&A around the eligibility criteria are somewhat looser. Certainly the PBS criteria are quite different to what we had been using with the National Medical Stockpile access. So just having that age factor has really changed access. So it's sort of age plus risk factors, not necessarily having to be partially vaccinated. So yeah, it's taking a little bit of getting used to, but these state guidelines are moving closer to the PBS criteria all the time. So hopefully Jackie's ready to go with the next case.
I am, although I might need Jenny to share her screen. Was it you that was sharing your screen, Jenny?
Oh yeah, do you want me to share for you and keep yours going?
Would you mind? Thank you very much. You know my technical. ability, which is probably about 0. Just a quick thing about the liver derangement, liver function test, all that sort of stuff. It needs to be child's class cirrhosis 2 or above. It's really, you do have to have cirrhosis, not just deranged liver function test. So you know, if your liver function tests are a little bit up because you're carrying a little bit more weight than ideal, that's not going to knock you out for Paxlovid. So just be clear about that, because that's handy, I think. I'm going to talk about Maggie, who is a Jackie Yeoh special. She's absolutely my favourite kind of patient. So if I can get you to change over to the next slide. Okay, Maggie, who is 27 years old, and she's done the right thing. She's immunosuppressed, so she's got 4 vaccinations, good on her. She's got a history of Crohn's disease, and she's unlucky enough to have joint involvement. And because of that, because of that and the Crohn's, she's been on infliximab, which, guys, I've got so good at immunosuppressants in the last 6 months, I can't begin to tell you. But she's been on that for the last 2 years, and that's obviously one of the immunosuppressants that you can use in this sort of area. She tested positive 2 days ago at a PCR. Symptoms started 1 day before that, so she is essentially day 2. She's got a bit of wriggle room, which is great, and particularly with these people, when you are trying to find your Paxlovid, first write your script, then go looking for it. You do have to ring around. You do have to check which pharmacies have got it in stock. You will find out very quickly in your area, and you know, just keep an eye on who's got it around and tell them to get it in. Often they can order it in for the next day if you let them know early in the morning. Okay, she's got good renal function. She's got lovely normal liver function tests. Her blood pressure is fantastic. Oh, quick thing about Paxlovid and blood pressure. I don't think we've actually seen anybody as yet who's had an increase in their blood pressure, but it is certainly something that can happen. We tend to see the metallic taste. That's what we tend to see most of, and about 6% of people get it. So I'm not at all surprised. And we do get a few where they're so nauseous and vomiting that they can't keep going. But most people are tolerating it very, very nicely. She has an infliximab infusion every 2 months, which is pretty standard. She's on the oral contraceptive pill. She's on an anti-inflammatory. And because she's got some chronic pain from her joint disease, she's on amitriptyline. See, I knew I'd make this nice and easy for you guys. She's on a bit of tramadol because I'm a glutton for punishment, and I'm going to get Joy and Deb to talk about that in a moment, because they've got some lovely pharmacy kind of orientated things on that. And she's also on duloxetine because of chronic pain, and she's on a bit of quetiapine at night because she's one of those poor people who's got a bit of psychological stuff going on, complex PTSD. So she's definitely a Jackie Yeoh patient. She also takes quite a lot of other things, and you've got to ask. Zinc, magnesium, she takes a probiotic. She's a little bit alternative. She takes slippery elm and a bit of iberogast because she's, you know, slippery elm was prescribed by the naturopath, and she thinks it's helping her tummy pain. And she smokes a bit of marijuana. And don't ask them don't talk about it as a recreational drug. I find it's most useful if you say, you know, are you using any other drugs that, you know, we can talk about recreational, but I often talk about any other alternative drugs such as marijuana, and I name it, to help with pain sleep, because they'll often tell you that, oh, that's not a recreational drug, that's what I'm using to manage my symptoms. She thinks it helps with gut spasms. Who knows? Perhaps she's right. But she has been able to go without it for a few days, if necessary, on occasion. Okay, on we go. Now, can she take it or can't she take it? Because for Maggie, well, she's not going to meet PBS criteria for molnupiravir. She's not going to meet it for, well, she could meet it for Paxlovid actually, but she's certainly not going to meet it for molnupiravir. So because she's so immunosuppressed, she would actually come into that bracket. I like making things as simple as I possibly can, because I'm not a complicated kind of person. So my principles of medication management with Paxlovid, having worked with it for some time now, are really basically, can you hold the medication for 5 days plus 3 days thereafter? So it's 8 days in total. If you can do that, great, hold it. And obviously, zinc, the slippery elm, all those sorts of things, not going to be a matter, not going to be a problem. Can you monitor the patient? Can you adjust the medication dose if required? Can you get them to keep an eye on the things that you're worried about? If you're starting to feel more sleepy, get in touch with me, we'll tweak your drugs. Can you do it that way? Can you monitor their measurements? In other words, can we get an INR done? And would you mind going back a moment so I could remember what I'm going to say? Thank you, sorry. Very tired brain. Can you monitor something about them? Their blood pressure, their INR with warfarin is the classic, and then fiddle as you need to. Can you put something else in its place? So that's your Seretide, and you stick in budesonide because it's got no salmeterol in it. Or can you tweak the medication dose temporarily? So hold, monitor, substitute, adjust. If somebody can come up with an acronym for that, I'll love you forever. Next slide. Okay, so what's Maggie got going on is going to cause us a bit of trouble. And more importantly, how do we get around it? Because the more you play with Paxlovid, the better you'll get at tweaking things. And you will find you get very good at this very quickly. Having trained multiple GPs now and written academic stages and all this sort of thing, you can actually manage this. It's not as scary as you think. Trust me.
Jackie, can you lean into your mic because your voice is breaking up?
Sorry. Can you hear me better now? Is that better?
That's better.
Thank you. Fantastic. So some of these are in the medication list and some of them are in the things that aren't in the medication list that we just talked about. So on we go. Next slide. Yep, thank you. Oh, sorry. Okay, so we're not going to worry about, oh, sorry, sunrise is about to die. Just a second, let me get rid of that. Okay, so the infliximab, the meloxicam, the duloxetine, absolutely all fine. Check them in your interaction checker. We're lucky in the hospital we've got up to date. It is a lovely interaction checker. I know some general practices have got it. I know not all of them have. I wish I could give it to you all. But the Liverpool is a pretty good option. And, the other people you can ring are, of course, DATIS. And they will help you. They absolutely will help you. We will too. Quetiapine, codeine, as in the quinidine fort, tramadol, ethanaldose, estradiol, and amitriptyline all do have interactions with Paxlovid. So here's your options here. Use the interaction checkers. If you can get hold of two, great. If in doubt, ring the lovely people who are in this webinar with us. They will help you. And they are absolutely good at this stuff. And I ring them all the time if I get stuck. Next slide. Okay, so don't be freaked out by all this SIP stuff. Okay, it used to freak me out. You get better at it. Okay, so quetiapine gets broken down by the CYP3A4 pathway. Ritonavir stops that, so you get more quetiapine. So basically, they're either going to inhibit something or they're going to break it down faster. So you've got more quetiapine. Well, we all know where that's going to lead. You're going to get more side effects of quetiapine. So my preference for Maggie would be to hold her quetiapine. I wouldn't do that with someone with bipolar disorder without talking to their psychiatrist. Well, I probably wouldn't do it at all, to be perfectly honest, but I'd certainly want to talk to their psychiatrist. That is the other key message here. If you're not sure, ring the specialist, have a conversation. We do it all the time in the CCC, and it's by far the best way of sorting this stuff out. If you happen to be the person who's prescribed it, you'll know better than anybody else whether or not it's safe to hold it. So that's what we're going to do with Maggie's quetiapine. She's not on much. We'll get away with that, I think. Amitriptyline. It's also broken down by one of these SIP little creatures. Ritonavir stops that. So you might get slightly higher doses of amitriptyline. It's not as strong as for the quetiapine. So we can monitor Maggie's clinical state and we could tweak the dose if we need to. Codeine. Well, this is where I get Deb and Joy into the mix because they are very good at this stuff. And I'm going to get them to talk about codeine and tramadol in a moment. So get ready, guys. But yeah, basically codeine also gets broken down by the SIP stuff. Then ritonavir can interfere. Basically, what can end up happening is that you can get less analgesic efficacy. So basically what you do is you monitor. You might need a slightly higher dose. You talk to your patient about it. You explain it. You give them your phone number. No, you don't have to give them your phone number after hours. But, if they can ring surgery, have a chat to you. We give them the CCC number. Obviously, we've got the advantage of being open 12 hours a day. I know you can't do that. But at least if you can give them a number to ring and then they can ring you up and check with you. Tramadol, yes, again, it's complex, but it's the same sort of thing. And again, monitor and adjust if needed. Joy and Deb, can I get you two to comment on this? Because I know you guys are going to explain this way better than I can. If you could just have a little talk about the joyful opiates that we've got here.
Yeah, thank you, Jackie, and hi, everyone. Look, it is really difficult, and with regards to, I think, my comments around codeine, it really depends on how reliant that person is on the codeine. Are they, and in this case for Maggie, she is on other medications that she's utilising to help manage her pain. It may be something that if she's only taking perhaps 2 by 30 milligrams of codeine a day at night, it may be something that she's not necessarily going to notice, particularly with the changes in the other medications. It's a little bit similar with regards to the tramadol. Again, if a person was solely reliant on codeine or tramadol in terms of their management of pain, and were on high doses of those, then it would be a different conversation. Deborah, I'll hand over to you if you'd like to make a comment, but the other thing amongst all of this is the changes of these levels of these agents that we also understand have serotonergic properties centrally, and what they might do in terms of other symptoms, and then the overlay of that with someone who is already unwell with COVID. So being mindful of those other interactions as well, besides just some of these metabolic interactions, but also some of the pharmacodynamic interactions as well.
Thank you, Joy. Deb, did you have anything to add to that?
I was just to add to Joy's comments is that, again, it depends on the individual patient, and also if they were on very high doses of codeine and they were using a lot of codeine, it's just a really good opportunity to highlight that in this case, the ritonavir would be affecting the when we convert the codeine to morphine for the active ingredient. So in this case, it would be that the person might be getting less codeine or less of the active ingredient morphine, and therefore, as clinicians, we need to be alert to they might get less analgesic effect. And if they're using very high doses of codeine, then it might even tip them a little bit into a withdrawal, and that could manifest as agitation, restlessness, some of the signs and symptoms that might actually think you've got some serotonin toxicity there, when it might actually be withdrawal from the opioid if they're on higher doses. But in the sort of lower doses of codeine, yes, it's just monitoring for analgesic efficacy. Thanks for the opportunity, Jackie, to comment.
Oh, not at all. Can I the friendship, one more thing, and that is that we've come across people who've been on buprenorphine patches, and what's the other thing, fentanyl patches. Can you just comment on that too, guys? Because, of course, the difficulty there is stopping the patch. Deb, I'm going to ask you, because I think you're both being too polite to each other. I think, Debbie, are you on mute? Okay. Well,
I'll jump in and say, sorry, is that again, it's very much a case of monitoring for this short period of time that the patient is on the Paxlovid and going to have the changes in effect. And I have to say, with the conversations that we've had with GPs who have been prescribing Paxlovid for patients such as on transdermal buprenorphine, it's been a very individualised conversation. If somebody is on, 5 microgram per hour patch, they are, stable on that, they're well supported at home. It's a conversation about watching and waiting and having open channels of conversation with the patient rather than jumping in and making changes. Again, those, if there is going to be any change, it's not going to kick in for a couple of days, and then it's going to be a delayed offset for those other 2 to 3 days after the Paxlovid is completed. So it's not going to be necessarily always a change in perhaps the dose of that opioid analgesics that's being used, and it's very much dependent on which one is being used and at what dose. So you can't make a blanket comment about those.
No, and it's a different interaction compared to codeine, because codeine requires 2D6 to be converted to morphine, which is the active ingredient, and so it's quite a different response with the buprenorphine. It's not the same interaction. So yeah, we can't group all the opioids together as Joyce highlighted, and they're quite different. And it may be that it enhances the activity of the opioid and therefore leads to, you know, increased sedation or drowsiness, for example, whereas the codeine interaction is quite different.
Thank you, folks. And I think what you've just proven is that if you're not sure, and that includes after you prescribe this medication and your patient is ringing you up saying, what's this side effect? Ring these guys, because they are just amazing at this stuff. And I will never equal what these pharmacists can manage in terms of interactions. They are just fabulous at it. Jenni, can I just get you to go on to the, thank you. Yes, and as I said here, don't panic. Just don't panic. You can get help and you don't have to do it all on your own. Just coming back to what Maggie's taking that isn't on her medication list, she's taking zinc and magnesium, and as Jenni said, hold them. Bottom line, because they can, and if the patient wants to know, they chelate the ritonavir, so they'll bind it. Just get them to hold everything. That's all supplements, minerals, herbal and alternative medications. It is so much easier than trying to work out what's in them, especially with some of the traditional Chinese medications, because you know your Chinese may be better than mine, but it is not easy to work these things out, and they often don't have all of the ingredients listed. And Maggie also smokes marijuana, which is broken down by good old CYP3A4, or 3A4. So you might get higher levels of marijuana, and no, that doesn't mean they're going to get wonderful. Don't just think about how you tell them this. They're much more likely to get the vomiting and nausea. And the same thing happens with amphetamines and other recreational drugs too. So if you explain that to people, they are generally pretty upfront about what they're taking, and they will be much more likely to be honest with you. And then you can have a sensible discussion about, can they actually hold those medication or those substances, and are they prepared to do so? And I've had some people who are quite happy to do it, other people who said, no, I really can't, and that's fine. At least we've got it out in the open and we're doing this safely. Next slide. Okay, so the oral contraceptive pill, which is also an interesting one. Look, the recommendation for Paxlovid is don't use it if you're pregnant or if you're breastfeeding. We haven't got the safety data yet. We may at some stage, but not yet. So what we basically say is use barrier contraception or abstain from sexual intercourse while you're on Paxlovid. And yes, it interacts with the oral contraceptive pill. Don't tell them to stop the oral contraceptive pill, please. Tell them to use barrier contraception or abstain from sexual intercourse while they're on it, and for one complete menstrual cycle afterwards. And that way you have covered things nicely. It's definitely not a good idea to stop the oral contraceptive pill, because then you're going to get into the strife that you're trying to avoid. Next slide. Okay, so can Maggie take it? Yes. And here's my advice, write it down. Write it down, email it to her, give it to a friend, take to her, email it to the chemist and get them to give it to her. I don't care how you do it, but it's often much, much better to write it down if it's complicated. And Maggie is a bit complicated. So stop the quetiapine for the next 8 days. See how you go with the amitriptyline. Reduce it if you feel more sedated. Ring me if you're not sure. Be aware that your pain medications may need adjusted. Monitor your pain. See how you go. Ring me if you're not sure what to do. Stop your marijuana for the next 8 days. Hold all your vitamin supplements and herbal medications. And yes, that means a slippery elm and iberogast for the same time period. And use barrier contraception or abstain from intercourse while you're on Paxlovid and for the next full menstrual cycle on your Levin. And that's what I do. Write it all down, give it to the patient, then they know exactly what they're up to, and give them a number that they can call if they're not sure. And I think next slide. Oh, whoops. Okay, nearly there. And you can do it. You really can. We've all learned you can learn this too. It's not as scary as you think. Give them a number to ring. Make sure that they ask you lots of questions, and they can ring you up if they need to ask questions. And please ask us for help if you're not sure. I will happily guide you through it. So will these lovely DATIS people. You know, the COVID care doctors will do. There's all kinds of people who can help you. Don't be afraid. Give it a go. Okay, that's all there is for me today.
Thanks, Jackie. We've had lots of questions coming through in the chat, and hopefully we're getting through all of them. Obviously, people are feeling quite overwhelmed with the idea of doing this prescribing, but I'll just reiterate, from those who are doing it, they have certainly found that it gets easier very quickly. And there are plenty of, there's, you know, the Gpat duty doctors are available 7 days a week, and we have DATIS, as Jackie said, and I've put their numbers up, and we'll be putting those up again in our resources. We're also looking at developing some resources to support GPs with autofills and kind of decision trees that you can just have as like a template for your notes as well. So I'm hoping to have that out on Friday. So don't be scared. And I think Deb is up next.
Yeah, and I will go quickly with these because it's really just to, you know, hopefully bring together some of what we've already discussed. And so Jim is a 68-year-old man, and it's a telehealth consult. You're a GP, the patient has made the appointment, and they report that they had symptoms 3 days ago. So that was the 23rd of May, which is day 0. Their positive rat test was only yesterday, but they're effectively now day 2, and the clock is ticking. They've got symptoms. Now, this is a person with Crohn's disease that you know well. They've got hypertension and Goold. They're on esomeprazole, telmisartan, amlodipine in combination, and allopurinol and azathioprine. So, you know, one of the, you know, you're quickly, you know, you're sitting there in the consult and you're thinking, well, is Jim at high risk of progression to severe disease? His vaccination, he's had 2 doses, his BMI is just under 30 and his EGFR is 72. So the first thing you might do is then bring up the PBS eligibility, and you're thinking, well, is this person eligible? Because, you know, they've tested positive on their rat, and you've checked that, and you've assessed their when they did it, and you've asked them about when they've uploaded that onto the SA Health website because of it's a rat positive, but also they've got a one sign or symptom, they're not hospitalised, and they're aged over 65. But are they at high risk? And the treatment must be initiated within 5 days. So you're nearly there, and you're wanting to think, well, what's the high risk? So then you go to the next part of the PBS eligibility, and really looking at this, they've had 2 doses, so they're not less than 2 doses and not unvaccinated. They're not over 75, and they don't meet those other criteria for being at high risk. So then looking to see, well, are they immunosuppressed because they're on azathioprine? And so then you go down to D and you see, well, azathioprine, they're at least, here it says at least 3 milligrams per kilo per day. And you are aware then that they're not meeting that criteria for being immunosuppressed. So this is the point where you're kind of thinking, well, will I ring DATIS before I or the clinician advice line to get information? Or you might go to the website, which Mel's already highlighted at the start of this webinar, and you might then choose to go down the NMS path and submit a referral. But you might want to check with either the clinician advice line or us before you go down that path. But in this case, you have decided to ring us.
Thank you, Deb. And today you've got me. It could be one of a number of our team that you might have. It might be Lauren, it might be Rose, it might be Trisha. So we are a small team and we work very tightly together, and we are on a steep learning curve and have been a fantastic ride. But you've rung us and you're thinking about the azathioprine. Is this really an issue? Not meeting the PBS criteria with the 3 milligrams per kilogram per day at a body weight of 78 and a current dose of 100 milligrams per day. However, interestingly, we ask you about all medicines that Jim is taking, and he's on the allopurinol, which seems pretty benign, except in this instance, it's being used for a very specific purpose, another interaction for the benefit of raising azathioprine levels. So allopurinol as a xanthine oxidase inhibitor increases levels not only of azathioprine, but also mercaptopurine, which may be another agent that is immunosuppressive and could be used in this patient group and a large number of patients with autoimmune disorders. So the effect of the allopurinol on the azathioprine is increasing the levels actually within the systemic circulation by potentially 3- to 4-fold. So even though on paper, the azathioprine dose is 100 milligrams per day, the presence of the allopurinol is significant. And in this instance, Jim actually does meet that PVS criteria then because of the presence of the allopurinol. It is not there for gout. It is there specifically for increasing the azathioprine levels. Now, the other option is that you could have also spoken to us with regards to the other pathway down the SA Health pathway. And interestingly, there, the criteria for the azathioprine is 1 milligram per kilogram per day or above. So he would have also met the SA Health criteria for consideration for Paxlovid as being immunosuppressed. So the choice then, I know there's been lots of chat, is going either with nirmatrelvir and ritonavir and is considered first choice based on the evidence of efficacy that we have versus molnupiravir. And we know that the eGFR is reasonable, and now we're going to look at, in terms of appropriateness, are there any other medications that Jim is taking that we need to be aware of? So in the discussion that we have with DATIS, we identify the combination telmisartan amlodipine as being a potential issue. Now, he's on a dose of 5 milligrams of amlodipine. Is that going to be an issue if the ritonavir elevates that 2-fold? Now, you might know Jim really well and go, well, actually, he's been on a high dose in the past, and I'm still been, and I've reduced it for various different reasons. And I wouldn't be too concerned if he did, for a short period of time, have an elevation in the amlodipine levels. Or you may very well know that in the past you have deliberately reduced the dose of amlodipine because Jim has experienced adverse effects such as swelling of the ankle, and you really don't want to complicate the picture at the moment with COVID by introducing potentially that adverse effect again. So that interaction is readily available and able to be explored on the Liverpool University COVID drug interaction website. Thanks, Deb, that was on the previous slide. Another tool that we use is a tool available to us through UpToDate, which is a subscription-based service. Another tool that we use, particularly for interactions with complementary medicines, is the Natural Medicines database. So we would often look at a number of different sites, and interestingly, between these two sites, there is slightly different advice, particularly with regards to the opioids that we were discussing before, Jackie. So not all of the sites agree. And it does require that overlay of judgment and knowledge of the individual patient, and you as a clinician helping us with that to make those decisions about drug interaction management. So in this case for Jim, thanks Deb with that next slide, is knowing about him is really important in terms of the managing the interaction with the amlodipine. So what is this? Is your GP? And actually this is the case that a hybrid of one that Mel had early on. In that particular case, in Mel's patients, the lady's BP was actually quite borderline anyway, and we made the decision to continue with the amlodipine as it was without making a change to that combination product. The challenge is, though, for Jim is if we are concerned about him becoming potentially hypotensive or adverse effects from the doubling of the levels in the amlodipine, even for a short period of time, how are we going to manage that as a combination product? Do we provide him with a script for the telmisartan as an individual agent? And that might be something that you do discuss. Do you provide a script for the telmisartan and the amlodipine as separate agents, knowing that then afterwards you can have both of those agents together? And I guess that all gets down to an individual conversation with the patient, and the Gpat GPs are getting very good, and Jackie very, very good at doing this all the time, and deciding for that person what is going to be the best decision for them. Understand that there may be costs associated with any of those decisions being made. So as Jackie went through with her lovely acronym, are we going to no change and monitor and have some follow-up with that patient? We could halve the amlodipine dose for 8 days and monitor, or we could withhold altogether the amlodipine for 8 days and provide telmisartan as a separate entity. I guess the most important thing with any changes that we are making that are temporary for the 8-day period is to make sure that the patient resumes back to their original doses from day 9 onwards. Thanks, Ted.
So thanks, Joy. And it's also then to highlight, well, Jim does decide to proceed with the Paxlovid, and so it's making sure then that the patient has the right information, that they know about when to take the medicine and what to do if there's a missed dose, and also to document that you've obtained informed consent, or it can be verbal or written. This is a provisionally registered medicine, and you want to provide a script that clearly documents the dose, and the frequency, also the duration, and also because it is a provisionally registered medicine, it's really important to encourage the reporting of adverse effects and report these to TGA. And again, that's something that we would be able to help you with, or other pharmacists and the clinicians that you might be working with, or you yourself, if you need some support with that, happy to assist in that regard. But it is important that we, collect as much information as possible around these new drugs that we're using in this context. But also, and again, acknowledgement to Dr. Belinda Capon for sharing this resource, and working with Belinda and all the amazing GPs at Gpat, and Jackie, where it's really just to highlight this has been such a team effort. As Joy said, we're a small team. You could get any one of us at the end of the line, and we've really appreciated when we've rung GPs, their support and responding, returning the calls and following up. But one of the things that Belinda's really highlighted is also the need to document this now in your clinical records. And she's developed an example template, which I know she's happy to share. I just want to highlight a couple of the, with whatever software that you've got, making it easy and making it routine and fitting within your workflow is going to make this easier going forward, and also facilitates the documentation in your clinical record. One of the things I really wanted to highlight as part of the counselling to the patient is never share this medication with anyone else. It's not only you, I think Jenni, you mentioned it earlier, and Jackie, about not writing a script and saying for people to have it if your symptoms get worse, because obviously it needs to be taken within a tight time frame, but also emphasising to patients not to share this medication with anyone else. There's lots of individual drug-drug interactions, there's the contraception issues, but it's really important to get that message across. As Joy said, it might be also how you communicate in writing with the patient around any changes that you might make. And it might be, for example, esomeprazole, there's no change, amlodipine, telmisartan. It might be, as Joy's highlighted, we've had a lot of interactions with amlodipine. It's surprising how many patients that have been referred, amlodipine is one of the drugs that they're on. And so, again, it might be, it turns out this patient's also on zinc, so you're telling them to hold that and providing that in writing to them. But it might be that it was no change in monitor, or it might not be half the amlodipine. It might have been withhold the amlodipine, being really specific about that, and also highlighting when to restart the medicine, and maybe following up with them around that. Just following up on in the chat, questions that have been raised tonight is on the PBS site, you can see there the CMI. If you just click on that, you get the consumer medicines information. So for you as a general practitioner, for it being dispensed in a community pharmacy, they would get the Paxlovid CMI, and you'll see that on that CMI, it tells the patient that this medicine has provisional approval and what that means. And so you might want to include that in your counselling to the patient, that this is a new medicine. And but as we know, we've also got the COVID treatment patient information sheet that's on the SA Health website with some pictures and additional information. But as we started at the start of this meeting, is and Mel's emphasised this, there's nothing more certain in COVID than there will be change. And there will be updates to that information, and there'll be, you know, and again, reach out to us if you want that additional information. The other thing I just really wanted to highlight is earlier in one of the Q&As is there's a lot of drug-drug interactions, and we know that the average number of medicines that a patient, an older person, is on is 7, plus they might be on an additional 3 PRN medicines. That's a lot to check, and it is surprising how many medicines our patients are on. You might also want to just click here for the PDF and have that to hand, where you also want to know what medicines don't interact, because that can speed up the process as well. There's also the resources that are on the SA Health website, which similarly give you which medicines are contraindicated, what is green. But some of those, how we manage them is what's really important going forward. And we're learning ourselves, the expertise, and I have to say that a lot of the immunosuppressed and immunocompromised patients, there's also a specialist involved as well, and reaching out to them, because managing those complex medicines is really important that you seek their advice before any changes are made to those treatments. So I think I'm handing back to you, Mel, and I think I've just gone over 2 minutes.
Thanks, Deb. That was great. And I appreciate, guys, that we're coming to the end of our allotted time. I did just want to share a couple of sort of final messages just to try and make sure we're all kind of just to round up what we've been talking about tonight. I just wanted to reiterate, as I've said in a few places now, please try to be prepared, I think, is probably the easiest thing we can do to try and speed up this process when it comes to actually prescribing. I know I've certainly spoken with our practice around trying to incorporate that pre-assessment about eligibility and suitability of different medications into chronic disease management planning process. You can even start to sort of socialise the idea of these different medications with patients during the consults that they're coming to you before they actually get COVID. You can mention it and sort of get them thinking about it at COVID vaccination clinics, at flu vaccination clinics. You can think about making sure that your high-risk patients have a relatively recent EGFR on hand. You can also encourage all your patients to request that any COVID test results that they have through the mass drive-through testing sites are actually copied to you. They are getting better at that. So just keep reiterating that messaging to your patients, and also think about maybe reaching out and doing some proactive sort of alerts to patients on your books who are on immunosuppressant medications. And that's where the PHN can also be of assistance, sometimes helping you utilise some of the software they can use to work with your practice software and try and identify patients who might benefit from having a bit of pre-assessment for this kind of stuff. I also, if I can make my slides move, which is always a challenge. Remember, you need to make sure that patients are willing to take these medications and that they're able to manage the oral regime. So think about swallowing issues. Always ask about over-the-counter medications, recreational drug use, and the ever-present issue of contraceptive planning. Think about documenting consent. We should have some good tools up towards the end of the week that you can use as kind of autofills within practice software that can have that some good words for you to use for some of that. You don't necessarily have to have a complex special form that patients fill out, but you just need to have the discussion with patients and make sure that you document that they are understanding and have fully consented. And also consider giving a written medication plan to patients around what to do with their usual medications while they're taking the oral antivirals, and when to restart anything that they've had to change or hold while they're on Paxlovid or molnupiravir. And also consider checking in during their course of medication. And I know that no one has any more time in the day to do more appointments, but if at all possible, just trying to check in with them or ask your practice nurses to check in with them with patients who are taking these medications, make sure they're doing the right thing with their usual meds and that they're managing these medications okay. I've also just thrown up a few links to some of the main resources mentioned. There is an infinite array of resources available to support this. And as I said, we're trying to collate all that so we can incorporate it into some templates for use in practice software as soon as possible. I think that's all from me.
Fabulous. Thank you so much to our panelists this evening. Now, I mean, don't feel overwhelmed. I think what really is evident here is there is so much support available to help you get through this. You've got the support of Deb and Joy through DATIS. You've got the support from our liaison team, from the COVID care centres, from Jackie, and then from our fabulous GPs at Gpat. And then finally through the PHNs. So we're really here to support you get through this and be able to help you make those informed decisions, particularly around your patients and how best they can access treatment, because this really is our best layer now as we combat COVID, is making sure we can get early access for treatment to reduce down the risks of people needing hospitalisation and ongoing comorbidities associated with COVID. So a very big thank you to everyone joining us this evening, and particularly a big thank you to Adelaide PHN and to Brendan as well for being online with us. We know that these webinars, and I had apologise, this is webinar number 7 for the year, I realised in that time then. Really grateful for everyone's support and particularly this panel tonight. This has been a couple of months in the making to get us here, and we were really keen to make sure once we had both drugs on the PBS that we were able to provide an interactive webinar, and particularly whilst it hasn't been a verbally interactive webinar with participants putting up hands, it's been great to see Q&As being able to be answered as we move throughout. So thank you so much to a fabulous team, and thank you to Brendan at Adelaide PHN for your ongoing support in the COVID response.